Hello and welcome everyone. We are now into week 6 of our knee injury rehabilitation course. In this week, we will be studying about rehabilitation of other ligaments like the MCL, the LCL and the PCL. We will also be studying about the meniscus injuries. We begin off with chapter number 26, MCL injury grading and phase-wise conservative and surgical rehabilitation of the MCL ligament. The objectives of this lecture are to understand the anatomy and biomechanics of the medial collateral ligament, to describe the grading of MCL injuries, and also differentiate between conservative versus surgical indication for MCL injuries. We will also learn the phase-wise rehabilitation approach for conservative management and recognize modifications in rehabilitation following surgical repair or reconstruction. We'll also apply evidence-based progression criteria for safe return to activity. So let's begin. Managed conservatively and high-grade tears which require surgical support. A phase-wise approach ensures structured progression from pain control, stability, muscular strength, and functional return. Both conservative and surgical pathways emphasize protecting the healing ligament while restoring full knee function. Now, we shall quickly brush up upon the anatomy and function of the MCL. This was already discussed in week 1 of this course. The medial collateral ligament has two components, superficial and deep. The primary job of the MCL is to resist valgus forces and help control excessive rotation of the knee. The MCL ligament works along with the ACL and medial meniscus to stabilize the joint. Because of its position, it is the most commonly injured ligament in the knee. So let's discuss the mechanism of injury and epidemiology of MCL injuries. MCL injuries usually occur when a valgus force is applied to the knee, with or without an associated rotation. A valgus force is a force directed from outer aspect of the knee to the inward aspect of the knee in coronal plane or frontal plane. The valgus force to the knee is commonly seen in contact sports like football, basketball, and rugby. It is also seen in non-contact sports like skiing, often causing rupture of the MCL. They are also frequently associated with ACL or medial meniscus injuries. Hence, a thorough assessment of the knee is crucial to get a comprehensive knowledge of the extent of the injury. The MCL injury can be graded by applying a valgus force to the injured knee of a patient. We classify MCL injuries into 3 grades. Grade 1 is the one with mild sprain and less than 5 mm of joint opening. This is usually seen in a low velocity injury. Grade 2 is a partial tear with 5 to 10 mm of joint opening, but it has a firm endpoint. A firm endpoint tells us that the ligament is not completely ruptured and there's some part of ligament which is still intact. Grade 3 is a complete tear with more than 10 mm of opening and with no firm endpoint. MRI is useful to confirm and assess associated injuries, if any. Most grade 1 and 2 injuries heal well with non surgical or conservative line of management. The goals are to control pain and swelling, restore the range of motion, to maintain the muscle strength, and to ensure knee joint stability. I hope you have not forgotten about the police protocol to manage acute injuries. Functional brace is commonly used during the healing phase, and it helps to mobilize the knee joint in pain-free range of motion. Importantly, loading must be progressive and within the healing tissue's tolerance. In the acute phase, we focus on reducing pain and swelling with ice, compression, and other treatment modalities. The knee is protected with a brace, often fixed at 30-degree flexion initially. Isometric quadriceps and hamstring contractions are encouraged to prevent muscle atrophy, and the patient is encouraged to walk with support and under supervision if the pain allows. The criteria to progress includes pain and swelling to be under control, full passive extension to be achieved by the patient, a straight leg raise without lag, and knee flexion more than 90 degrees. ROM is gradually increased with the goal of achieving full motion by week 6 of rehab. Strengthening is advanced using closed kinetic chain exercises and resistance band. Core stability and hip strengthening are integrated. Balance training like single leg stance or with wobble boards are encouraged while the patient continues to wear a functional brace. The criteria to progress to the next stage are a full knee extension and flexion of more than 120 degrees, minimal effusion at the knee joint, good quadriceps control in close kinetic chain exercises when seen and supervised by the rehab personnel, ambulation with normalized gait, with or without using a brace. Phase 3 is started when sport specific and dynamic drills are introduced. Strength and endurance are emphasized upon. Neuromuscular control is restrained with agility drills. Low level plyometrics are added towards the later stage, depending on patient tolerance. And as discussed previously, return to sport is based on objective criteria, not just time. The criteria to progress is full and pain-free range of motion, more than 90% strength symmetry versus contralateral limb, good single leg stance balance of more than 30 seconds, and no valgus collapse during squatting, step down tasks, etc. Isolated MCL injuries are rare. Usually, they are seen along with ACL injuries or with meniscus injuries. Hence, surgery is rare for isolated MCL injuries too, but it is necessary in certain cases. These include the grade 3 injuries with persistent valgus laxity, or if it is associated with multi-ligament injuries involving ACL injury or PCL injury. Distal avulsions where tissues get trapped and this prevents healing. Surgeries are also indicated in this case. And most importantly, surgery is indicated when, even after a full conservative care, the athlete is rehab after surgical repair is far more cautious. The repair or graft needs protection with a brace. The range of motion progression is slower than in conservative management. Closed chain kinetic exercises and strengthening forms the backbone of recovery. The return to full sports usually takes 6 to 7 months depending on healing of the injured graft. The rehab protocol is quite similar to that of conservative line of management, but the progression is much slower. This progression should be criteria based and not time based. Return to play requires meeting objective criteria. The patient should demonstrate and have full pain-free range of motion of the knee. The quadriceps and hamstrings should be at least at 90 to 95% as strong as the uninjured limb. Functional hop and balance tests should be passed by the patient. The functional hop tests include single hop, triple hop, crossover hop, and timed hop test. Patient should also be able to pass the Y balance test with more than 90% symmetry. The athlete or patient should also demonstrate psychological readiness and not be hesitant while performing any of these activities. Clearance should then come from the treating physician. To conclude, I'd like to say that most of the MCL injuries are low grade and are treated conservatively with extremely good results. The rehab for MCL injury is phase wise and criteria based. Surgery is only reserved for grade 3 or complex injuries only. A safe return to sport depends on strength and neuromuscular readiness of the athlete. These are few of the references that I have quoted and mentioned in my lecture today. We will be continuing with injuries to the remaining structures of the knee, namely the LCL and the PCL ligament, and also the meniscus in subsequent lectures in this week. Thank you for your time. Have a good day.